Welcome. Today we are looking at local anesthetic systemic toxicity, or LAST, in tumescent vein procedures. Our goal is straightforward. Understand the specific timeline of this condition and master the exact life-saving algorithm used to reverse it. Tumescent anesthesia involves injecting large volumes of highly dilute lidocaine into the subcutaneous tissue surrounding a vein. As the fluid infiltrates, it expands the tissue space to provide both local numbness and vessel compression. Because we use such large volumes, timing is everything. Look at this split-screen timeline. If a patient is undergoing liposuction with tumescent anesthesia, peak serum lidocaine levels are delayed out to 12 to 16 hours. But for a non-liposuction vein procedure like endovenous laser therapy, that peak happens much earlier, right here at the 1 to 2 hour mark. To keep serum levels below the toxicity threshold, the estimated maximum safe dosage for these non-liposuction vein procedures is capped at exactly 28 milligrams per kilogram of lean body weight. That distinct 1 to 2 hour peak defines our clinical workflow. Because the absorption is delayed but significant, patients cannot simply be discharged immediately after the procedure. Clinics must actively monitor them for at least 30 to 60 minutes to ensure no delayed toxicity symptoms emerge. Toxicity follows a distinct progression. It starts with central nervous system excitation. Watch for a metallic taste, perioral numbness, tinnitus, or confusion. Without intervention, this rapidly transitions to severe depression, presenting as an acute seizure, and ultimately cardiovascular collapse with severe bradycardia and cardiac arrest. To intercept this sequence, prevention is key. First, use strict weight-based dosing calculators. Add epinephrine to slow systemic absorption. Use ultrasound to avoid blood vessels, and completely avoid heavy midazolam sedation. That last point is crucial. Midazolam masks early central nervous system warnings. Maintaining continuous verbal contact with an awake patient is your most sensitive monitor. It's the only reliable way to catch toxicity early before an irreversible cardiovascular event. If prevention fails and LAST occurs, your response requires a complete pivot. Standard Advanced Cardiac Life Support, or ACLS, will actually worsen a patient's condition. Instead, you must immediately switch to the specialized ASREL LAST checklist. The algorithm starts with immediate damage control. Step 1 is to stop injecting the anesthetic and call for help. Step 2 prioritizes the airway. You need to ventilate with 100% oxygen to prevent hypoxia and acidosis, both of which severely exacerbate cardiotoxicity. Step 3 addresses the seizure activity. Administer benzodiazepines to calm the nervous system. You must strictly avoid using propofol for seizure control here, as it will trigger fatal cardiovascular depression in a patient already suffering from local anesthetic toxicity. At the first sign of severe systemic toxicity, we deploy the primary antidote, 20% IV lipid emulsion. This requires an immediate initial bolus of 1.5 milliliters per kilogram, followed directly by a continuous infusion of 0.25 milliliters per kilogram per minute. This works through what we call a lipid shuttle. The infused lipid molecules enter the bloodstream and act like a sponge, physically absorbing the highly lipophilic anesthetic molecules and pulling them away from the vulnerable tissues of the heart and brain. The cellular blockade caused by heavy lidocaine toxicity simply does not respond to standard chest compressions and adrenaline. Applying this lipid shuttle protocol is the only effective method to directly reverse the molecular cause of the collapse. If cardiovascular support is needed while the lipids circulate, use a modified approach. Treat bradycardia with atropine. For hypotension, use strictly low-dose epinephrine, keeping it under 1 microgram per kilogram. Large, standard ACLS doses of epinephrine will severely worsen the toxicity. Let's pause here to test your recall on the core prevention metrics. For a non-liposuction tumescent vein procedure, what is the maximum safe dose, and when does the serum lidocaine reach its peak? The absolute limit is 28 milligrams per kilogram of lean body weight, and that level will peak in the bloodstream between 1 and 2 hours post-injection. To review the rescue algorithm, your 5 essential steps are: stop the injection, secure the airway with 100% oxygen, control seizures with benzos, administer 20% intravenous lipid emulsion, and manage blood pressure with only low-dose epinephrine. While LAST is exceptionally rare in daily phlebology practice, the stakes are absolute. Having immediate on-site access to 20% ILA and strict adherence to this rescue checklist is a non-negotiable standard of care that every clinic must maintain.